Okay, respond to a seizure call. Again, these are the type of calls where you're not really sure what's you're gonna find when you get there. Maybe a full-blown active seizure, maybe the post-ictal. This particular patient, all we really got as far as pre-arrival is that it is a female in her mid-50s, so no history that we know of seizures. This can be tricky because maybe this is a new onset of seizures, so you have to kind of think about maybe it's some type of a brain issue going on. Maybe it's a hypoxic type of a seizure due to some type of respiratory issue, or maybe even it's a seizure just prior to a patient going into cardiac arrest, which many times can happen as well. So we're not really going to be sure until we get there when we find out, but this is going to be one of those ones we're going to be asking a lot of questions to get a good patient history and find out what's going on. I'm kind of thinking. So again, you're going to think about your seizure treatments and other options available to you, but I'm going to take a look and I'll let you know what we found when we get on the other side. Okay, so we're clearing up from the seizure call, and this is one of those calls again where you're not really sure what you're going to find when you get there, and it turns out that there wasn't really a seizure at all. I'm not quite sure where the seizure complaint came from or how the dispatcher wound up getting it that it was a seizure complaint. But it's also one of those calls where the family was convinced that something was going on, and they had a little bit of medical education, and they were kind of fixated on that complaint and kept telling us that the patient had a TIA. Now, there was no neurological deficits that we could find on the patient. She was alert and orientated, but she was weak and a little bit on the warm side. Now, the patient did have a recent brain surgery history going on, but all in all, she was still alert but weak. So it was kind of hard to figure out exactly what was happening. She would be able to move all of her extremities, and vital signs were pretty much within normal limits. So this was kind of a tricky one to figure out, and we tried to ask the family as far as recent history and events leading up to the present emergency, and even going a little bit further back on some past medical history with no seizures in the past, no TIAs in the past, and no CVAs in the past, just the recent brain surgery. So the family feel that that was what was going on. One thing to note, the patient was on some heavy steroids that they were getting recently taken off of, and the patient did have a known sensitivity to a steroid withdrawal, and it's possible that maybe their weakness and might be due to being taken off the steroids. In addition, the patient did have a physical therapist that day at the home, and maybe worked a little bit harder than usual with the physical therapy and was kind of drained. So this is one of those calls that there's not a lot we can do for the patient because not a lot of pinpoint complaint going on and nothing that's life-threatening. So what do you do with this type of a patient? Well, again, you're going to get as much history as you can for the emergency room, get all the medications, including dosages if possible, and go ahead and just kind of monitor and transport to the hospital. Even start an IV in a patient like this, since you don't have a lot of history and a lot of information, especially if the family is convinced one thing is going on and not really kind of cooperating with what the line of question that you're asking them. You're better off starting an IV just in case something starts to evolve on the way to the hospital. You want to be prepared for that. You don't want to start trying to start an IV and getting an EKG and all that stuff when the patient starts to have some type of emergency evolving en route to the hospital, and then you have to start trying to get an IV in place and think about getting IV access and stuff like that just in order to treat them. So while they're stable, while there's not a real big emergency going on, go ahead and start that IV, get your EKG, maybe put them on oxygen, whether it's nasal cannula, non-rebreather. Go ahead and do that and get your treatment, at least your baseline treatment, started, and monitor and transport, and of course be alert for any changes en route to the hospital. Unfortunately, in this call, I wasn't able to speak to the doctor after the assignment to find out maybe what was going on with the patient, so I can't really tell you what the final diagnosis was, but we did arrive at the hospital without any incident, and there really wasn't any change in the patient's condition. So, in my opinion, that call was a success. We had no negative outcome in the patient, and it's just important to note that sometimes when you get family members who have a certain thing in their mind, they're going to try to lead you on the path on what they're thinking. But of course, as the medical professional, as the EMS provider, we have to kind of take a step back and, while yes, take the family's information into consideration because they are the family, they're familiar with the patient's history and what's going on with the patient, we have to still take a step back and take a good patient history and physical exam just to make sure that nothing is being overlooked and that we're not going to just get that tunnel vision going by what everybody on scene is yelling at us and not overlook something. So that's really the takeaway in this point, is to just make sure in calls like this to take a complete patient history and take into consideration what the family says, but at the same time use your clinical judgment, your patient assessment skills to try to figure out what's happening with the patient and treat appropriately. Okay, well, that's it for this edition of Virtual Response Medic. We'll see you on the next response we do. And as always, this is Jim Hoffman, and stay safe.